G'day, Menshealth.physio Tom Harris here, and welcome to the channel. For more than 10 years, I've assisted thousands of men through their prostate cancer treatment journeys. With this experience, I'm looking forward to sharing more of my skills and experiences to assist more men through their own prostate cancer journeys. Prostate cancer is the most commonly diagnosed cancer in Australian men, and for many of those men, weight and metabolic health will quietly shape almost every decision that follows. Whether surgery is possible, how safely it can be performed, how well they'll recover, and even how the cancer itself behaves. Today we're exploring a topic that sits at the intersection of urology, obesity medicine, and oncology, and it's one that is generating real excitement in the research community. The use of GLP-1 receptor agonist medications, a class of drugs that include well-known weight loss injections, has risen dramatically among men living with prostate cancer. In 2016, around 2,000 men with prostate cancer were using these medications, and by 2024, that number had grown to nearly 70,000 men. That is a remarkable shift, and the science trying to understand what it means is moving quickly. Fascinatingly, researchers have now identified GLP-1 receptors on prostate cancer cells themselves, suggesting these medications may one day be found to do more than manage weight. But we'll let our guests speak to that. I'm joined today by two clinicians who bring complementary and deeply relevant expertise to this conversation. Dr. Jonathan Chambers is a urological surgeon at Brisbane Urology Clinic, consulting and operating across Brisbane, Ipswich and Rockhampton. He's a Queensland-trained urologist who completed his medical degrees at the University of Queensland before obtaining his surgical fellowship through both the Royal Australian College of Surgeons and the Urological Society of Australia and New Zealand. He then went on to complete subspecialty fellowship training in minimally invasive robotic surgery at the Royal Brisbane and Women's Hospital. Jono's clinical focus is robotic radical prostatectomy, one of the most technically demanding and consequential operations in men's cancer care, along with the broader management of urological cancers. He also holds a Master's from Public Health from the University of Queensland, which gives him a perspective on cancer care that goes well beyond the operating room, with a particular emphasis on quality of life outcomes that matter most to patients. He currently holds the position of Senior Lecturer at the University of Queensland, contributing to the next generation of surgical training. Dr. Paige Lanyon-Roberts is a general practitioner and bariatric doctor based in Brisbane, and the founder of MedSurge Weight Loss, a specialist obesity and metabolic health practice operating out of Brisbane with telehealth services available across Australia. She graduated from Griffith University Medical School in 2011 and holds a fellowship of the Royal Australian College of General Practitioners with formal recognition of extended skills in obesity management. She also holds World Obesity Scope accreditation, an internationally recognised credential in obesity care, and is an associate member of the Australian and New Zealand Metabolic and Obesity Surgery Society, as well as a member of the Australian and New Zealand Obesity Society. What makes Paige's background particularly relevant to today's conversation is the rare combination of medical and surgical experience she brings. She has over 10 years of experience as a surgical assistant in general and bariatric surgery and has contributed to the care of more than 1,000 patients undergoing procedures, including sleeve gastrectomy and gastric bypass. She works closely with bariatric surgeons across Brisbane, the Sunshine Coast and the Gold Coast, and has developed additional training in eating disorders, reflecting a genuinely holistic approach to metabolic health. Together, we're going to cover the full picture from how excess weight affects surgical planning and anesthetic risk, to the role of GLP-1 medications in preparing for surgery, to what patients should be eating, how to protect muscle mass, and what happens on the other side of the operating table. Whether you're a patient facing a prostate cancer diagnosis, a partner supporting someone through it, or simply someone wanting to understand this rapidly evolving space, we hope today's conversation gives you something generally useful. So let's get into it. So Jono and Paige, thank you for joining us today to discuss the role of GLP-1 medications in prostate cancer treatment and preparation and rehab for men diagnosed with cancer. Quick couple of things that I found interesting doing a quick little background recent kind of research was the interesting rise in men using GLP-1 medications with prostate cancer. So there's a large database study back in 2016, I think it was. There's only about 2,000 men on these medications. And now when we jump forward to 2024, there was just shy of 70,000 men. So there is a big kind of increase in men using these medications with prostate cancer. I found it quite interesting, and Paige, you might have more later on, but the fact that they're kind of finding GLP-1 receptors in prostate cancer cells themselves, which is quite a fascinating kind of research field in the GLP-1 sector of kind of where else these receptors are and how things change. So we can't say that GLP-1 medications will cure prostate cancer, but it is quite interesting that there are receptors there, and who knows where the research will take us in the future in that space. And so to start off with, Jono, patients always like to know, how did you get into, what brought you into the field of urology?
Yeah, that's a good question. My family often asks that question too, to be honest with you. But no, urology is just quite a diverse field in surgery. I went down that pathway. I think we all get influenced in medicine just by the people that we work with a lot. Probably just some of my early mentors were very nice urologists, as most urologists are. And I took a pretty strong interest down that pathway. We've got a great and varying degree of complexity in our operations, and we often form long relationships with our patients because of the treatments or the conditions that we treat, really, and the treatments that we give. And in particular, I enjoy the pathway of prostate cancer. Yeah, and we have some long-term patients there as well, but I do a lot of robotic prostate cancer surgery, and so that's pretty cool as well. I've dreamed for a very long time since I was little of playing on a $3 million computer console every day, and that's what I do. So it's fantastic. That's the short story.
Yeah. And Paige, what led you down into bariatric type medicine?
Well, actually, my story also begins in the theatre, starting out as a surgical assistant in bariatric surgery. So I was helping out a surgeon while I was doing my general practice training, and we would operate on 20 to 30 patients per week performing weight loss surgery. And it became quite clear to me that these patients didn't have anywhere to go after their operations, and really managing a patient who suffered from excess weight for their life. They really do need lifelong care. And so part of my general practice started to be focused on patients who had lived in larger bodies and in particular who were recovering from bariatric surgery and looking after them. Again, like Jonathan said, that lifelong care for the patient. And as we know, the rise of GLP-1s over the last few years with the successes that we see with weight management and all of the other areas that these medications are permeating into, it just called for a multidisciplinary practice to be set up. And so now I run MedSurge Weight Loss, where we have 5 clinicians and an allied health team here to support patients through their weight loss journeys, whether it's on medication or through bariatric surgery. And we work very closely with the team that Jono works with at Brisbane Urology Clinic to help patients who are preparing for prostate cancer surgery and also for their health beyond as well. So that's me.
There you go. Very interesting. And Jono, back up to you. In terms of men with prostate cancer, so in terms of like planning treatments for someone that's been diagnosed, what kind of role does weight and excess weight play in terms of deciding on which treatments might be available to that patient?
Yeah, it's a really great question. And it's one that, all urologists really consider when they have a patient that walks through the front door with a diagnosis of prostate cancer. It's probably the very first thing that goes through your mind is just you see a patient, you see their BMI, essentially. That's the first thing that hits you. And you think, well, already there's going to be either some challenges in terms of outcomes from that or pathway or not. And so just in terms of weight and prostate cancer journey, really huge implications for treatment. First of all, actually operative planning and just getting through an operation, weight and associated metabolic conditions really can put patients at an increased risk perioperatively, either before or after or during an operation, essentially. And so it's a massive consideration, not just weight, but all the other things that come along with that. Really what we're looking at from a prostate cancer pathway perspective and from a surgical perspective is, how are they going to get through a procedure safely, and also how they're going to overcome the functional implications that occur with prostate cancer treatment. And the big things there really being the post-operative initial recovery, but then obviously urinary incontinence plays a big role, and also rehabilitation afterwards, just getting back to a normal lifestyle. Probably a few of the big factors that we initially see.
And the in terms of like the surgery side of things, like what kind of challenges can increased abdominal fat and visceral fat play?
Yes, great question. And so I think, first of all, it's actually your ability to have an operation, really. When 98% of prostate cancer surgery in Australia is done minimally invasive robotic surgery, and so it should be. It's it's associated with better outcomes and less major complications. Surgery does involve a patient to undergo a general anaesthetic, and so that puts stress on the body immediately. The position that they're in, their head's slightly down. They have it's called a pneumoperitoneum, so we fill up their abdominal cavity with carbon dioxide gas to get some vision there. And so already there's a lot of pressure on the inside, which is also pressing the body reserves as such. So that's just going off to sleep, and sometimes that can cause some distress physiologically to the patient. Operatively, it's a real game changer having a bit more intra-abdominal fat, because that's where we're operating, and your prostate sits deep down in your pelvis in a very tight little space there. And intra-abdominal fat just sits there as well, unfortunately. And it really can make mobility quite difficult and vision quite difficult, and can compromise things in terms of being able to achieve a really great nerve-sparing procedure or good visualization for an excellent anastomosis between the bladder and the urethra, when we're repairing things together. So a whole range of things anatomically from a surgical point of view intraoperatively. But they're probably the main things that we look at. It's like your dream when someone comes in and they've got lower intra-abdominal fat and a prostate that's just sitting there that just wants to come out straight away. It's beautiful. It's glorious. Yeah.
I saw a very interesting note that I hadn't seen before on someone's file just the other day. The quote was, "It was a virgin abdomen." And I was like, I'd never actually seen that written before. And I was like, that's a great way to put it.
Yeah, well, high five when it happens. It's great. It's, that's the first abdomen is an abdomen that has not been entered into surgically before. And that used to be a really big thing because of intra-abdominal adhesions and things like that. But probably less so these days. But yeah, feel good to hear. Yeah.
Yeah, because a lot of people wouldn't probably quite realize, and Paige, you can probably add more, but like when fat stores are there for a long period of time, they start to create their own blood supply. And I've been lucky to watch a few prostatectomies over the years. And I remember watching one where the urologist was getting a bit frustrated because there was more blood and clouding up his vision, and it was much slower to get down into the prostate. And then you compare that to watching one a year or two later for someone who wasn't carrying as much weight, and it's a very, very different procedure.
I think it's important to note as well, Tom, is that, and like you've already mentioned, it's that visceral fat that plays a big role in risk. And when we're talking about visceral fat for the patients listening at home, we're talking about the fat that lives around the abdominal cavity, so inside the belly. And it's the stuff that's behind the muscle deep within the belly cavity, not the stuff that's in front of the muscle, which is called subcutaneous fat. Not only do we see increased risk of diseases like type 2 diabetes, cardiovascular disease, but it's also very inflammatory as well. And so it can affect healing. Like you said, it creates its own very complex blood supply that makes the operation more bleedy, and that in turn increases complication risks. But like Jonathan mentioned, it just gets in the way. So it really obstructs the view for the surgeon to be able to get in there and do the operation. think we're going to touch on this later, but not only that, the surgeon might find it a bit more difficult, but the anaesthetist finds it more challenging as well because, as Jonathan mentioned, patients lying 30 degrees head down, all of that weight is now centered on their breathing muscle. And the anaesthetist for the next few hours will be using a machine to breathe for that gentleman. And it can make it very challenging. In fact, Jonathan, we've had patients that weren't able to be anaesthetized and they had to abort their procedure at the time of the anesthetic. They came to see us, achieved a not a huge amount of weight loss, but a meaningful amount of weight loss, went back and safely had their operation a few months later because of that reduction in visceral fat.
Yeah, so that was going to be my next question, actually, about the anaesthetic,
Stole it.
the anaesthetic challenges. So yeah, the head down's an issue, the excess weight on the area, and then often, unfortunately, with excess weight comes up normally in a couple of other comorbidities at least, and they can affect anaesthetic risk as well.
Absolutely. So obesity itself drives over 200 different diseases, of which we see a significant amount of cardiovascular disease, obstructive sleep apnea, type 2 diabetes, insulin resistance, asthma, airways disease, a host of other things that the anaesthetist will have to take into consideration when they're doing the anaesthetic. We have some fantastic anaesthetists, and certainly the anaesthetists at Brisbane Urology Clinic that work with the guys there are highly skilled technicians. But when you have a patient who does have these comorbidities, it does create a very challenging and risky situation from an anaesthetic point of view. So weight loss preoperatively not only helps with surgical outcomes, but it also helps with ease of anaesthesia. It helps to optimize those diseases that those patients might be suffering from. So, for example, if we've got enough time and somebody we suspect might have sleep apnea, if we can diagnose and treat that, we can actually see some what we call heart remodeling. The heart will actually perform better if we can get that patient onto a CPAP machine for a month or two before that anaesthetic. So all of these things really tie together to optimize a patient and give them the safest anaesthetic and then the safest surgical outcome as well.
Yeah, that's great because we know sleep apnea can also drive nocturia and urine production at night and keeping men awake for longer overnight as well.
Yeah. And then when you're awake longer, you're actually hungrier the next day as well. So it's a bit of a
Absolutely.
self-perpetuating problem. Yeah.
Yeah. I suppose one of the most common questions patients are always going to ask is like, how much weight do people need to lose before surgery? Like, is there a number or a percentage that they're kind of aiming for to get a meaningful outcome?
Meaningful outcomes for weight loss occur from as little as 3 to 5%. Even so, if a chappie is, for example, 130 kilos, if he could lose 8 kilos, he'll have a significantly better outcome from his surgery and his anaesthetic. We aim for the highest amount of weight loss that we can safely achieve prior to surgery. And this is important, and no doubt we'll get into this conversation as we go. But we don't want men to starve themselves to achieve that weight loss because that creates some big nutritional challenges and it actually makes them worse off in terms of their anaesthetic and their recovery. So we want safe weight loss as quickly as we can, taking into account all of the nutrition requirements as well. So anything between 5 to 10% before surgery would be ideal.
And like we're seeing, Jono, like more and more often, like 11 years or so ago when I started seeing men with prostate cancer, 99% of the time it was like, when did you get diagnosed? And it'd be 4 to 6 weeks ago, and when surgery in 2 or 4 weeks' time, like it was very short windows. But now awareness is better all the time. People are getting diagnosed earlier, and now it's not uncommon for men to come into the clinic for their physio side of getting prepared for surgery. And, they were diagnosed 2, 3, 4 years ago.
Yeah.
So we do have kind of different windows of preparing these patients. So are you starting to refer some of these patients that are on kind of active surveillance, like the Gleason 6, that are kind of, probably late 50s, early 60s and likely to progress over time? Are you starting to send some of those off to start having the chat about the weight loss earlier?
Yeah, absolutely. And I think that's the whole crux of it in terms of prostate cancer treatment. We're lucky in a way that it is not the natural history of it is slowly progressing in most cases. And so We've become much better at diagnosis, early detection and treatment, as you mentioned, with things like MRI scans and also managing that low risk prostate cancer very well. So the patients that we recommend have surgery tend to need to have that surgery, and we get a big run up, a long pathway to offer that to them. And so, yeah, we take that on as an opportunity to improve their whole health. And a huge part of that is that weight loss journey and also making sure that they can keep that weight off ongoing. And so it's easy to jump on and prescribe these medications that may improve weight loss, but it's that lifelong benefit that we're aiming for. And that's where we have a pretty close affiliation with Paige and the team at MedSurge Weight Loss, because they do have a big team involved there that really do help get that weight off, but then also those patients tend to keep that weight off as well. And that has many, many additional life years benefit, not only life years, but just quality of life. You know, these guys, as you see, Tom, they come back 12 months, they've lost weight, they're actually a bit happier almost that, you know, they've kept that weight off and they're feeling more comfortable about things and happier in health. Yeah, that's the main benefit I think that we've got from this long run up of prostate cancer, and really a window that we need to jump into pretty early, as you mentioned. People are pretty keen to go down that pathway as well.
Yeah, the exercise oncology world, we often talk about as like cancer is like a teachable moment kind of thing.
Yeah,
And
absolutely.
And a lot of men, you know, we see the weight loss, we see men going from 12 to 18 stubbies a day down to nothing, and huge kind of changes, which is really positive for their health. You know, it sucks they got cancer, but there's often some health benefits that come out of it as well after the initial shock and kind of recovery stage. And then for some of our other men, so another area that I see a lot of men from is actually the Clarence Valley, like down near Grafton, Northern New South Wales. And interestingly, I was at a talk recently, and they've got some of the highest rates of Gleason 9 cancers, like really late diagnosis. There's no urologist in town, and there's often a bit of a late kind of access to services. So a lot of those men are kind of more back at the shorter windows, you know, like 4 to 8 weeks before surgery. How much weight could, on like a supervised program, Paige, with the team, like how much weight could they kind of anticipate on losing in the run up to surgery?
We have, and like you said, it's within a very supervised program. We've had chappies lose 20 kilos within 6 to 8 weeks before their operation. These are gentlemen that started with higher weight set points, so 150 kilo gentlemen getting down to 130, which really they were inoperable. They were not able to have their operation, and they had a cancer that was going to take their life in the next few years. And with that 20 kilo weight loss, they were able to make it to the operating theatre, have their operation safely, they recovered well, and their life has changed forever. And like you said, a lot of gentlemen will use this opportunity to continue their weight loss and health journey as well. But not everybody needs to lose 20 kilos leading up to surgery. So if a chappie is, say, 100 kilos and he's got a lot of visceral fat, even 7 kilos would be a big difference for him, for his safety, for his procedure. And that's very doable in that time frame.
Yeah, right. That's yeah, it's amazing. And that's a huge change.
It all counts on the inside as well.
Yes.
Yeah.
Anything that Paige and the team and the patient can get off, it really, everything makes a difference. It's amazing. Even a few kilograms can really make a huge difference in the operative pathway of things, the way that we look at things. And yeah, anything is fantastic from our perspective, from a surgical perspective.
Yeah. And it also helps, like it helps on our exercise side of things, because there's often a snowball, like someone gets a knee injury, they stop running. As they get older, they put on a few kilos and then want to try and lose the few kilos, but then the knee's hurting because there's added weight. And then it's just kind of a cycle that they just can't get off. So a lot of these men, they're much more engaged in getting back into the exercise when they've lost even just a couple of kilos. They're feeling lighter. They're finding it easy to move, and the knees aren't as aching as much. So they're getting the added benefits from that as well.
Yeah, exactly. When men have excess visceral fat, they tend to also have an increased risk of poor sleep quality or even formal sleep apnea, and you're not sleeping properly, you're not going to have the energy the next day. And so even just modest amounts of weight loss, it will start to create a flow-on effect in your sleep quality, your energy levels, which then you can actually have some energy to get up and do those exercises as well.
That's excellent. Paige, we're going to throw to you, and we're going to jump straight into these GLP-1 medications. And so we'll start off with just, what are they? Like, how do they come around and how do they kind of work essentially?
I love the GLP-1 medications. They have truly been a game changer. It's probably the first time in medical history that I can think of where people are actually knocking down the door to their doctor to say, I want to hear about these medications. I want to know about them. And for very good reason, they are absolutely life-changing. It all started really a long time ago when scientists sort of realized that there was a molecule in our bodies that were helping with appetite suppression and blood sugar regulation. So we naturally make GLP-1 molecule in our body. And this molecule in us, when we eat food, will naturally rise, and it's an appetite suppression at the level of the brain, but it also helps our pancreas to create insulin to store blood sugar. So it's very good for blood sugar management, and it turns off the appetite in our brainstem. However, our GLP-1, it only lasts for about 90 seconds and then it's gone out of the body. And so these hormones were investigated scientifically in the late 60s when a scientist found that there's a not very hungry lizard called the Gila monster who has a lot of GLP-1-like molecule in its saliva. And so they extracted that saliva and they made our first GLP-1 medication, which we used in 2005 for the first time for the treatment of type 2 diabetes. Now, this molecule evolved over time. This GLP-1 molecule lasts for about 3 hours. And so people were getting very good blood sugar control. Didn't do very much for weight loss. But as technology has evolved in this field of medicine, we've been able to stabilize those GLP-1 molecules to last a longer time in our body. And so currently we have 2 weekly weight loss medications that use the power of GLP-1, but the molecules will last for 1 whole week in the body compared to our 1-minute molecule that we make naturally from our stomach, from our small bowel. So you get a lot of appetite suppression, you get very good blood sugar control, and those effects last for a whole week instead of 1 minute. So people will eat smaller portions, and it's through that reduction in calories that they achieve weight loss. Now, if we tried to do that without the medication, our brain would fight back and it would increase our hunger drive and decrease our fullness feeling to try and restore our weight. And so when we're using these medications, we can actually eat less, but we're then not driven by that hunger to get us to restore our weight. And so that's why when people are using them, they can achieve weight loss. And as long as they continue to use them, they can maintain that weight loss as well. We do find that when people stop using the medications, the biology of the brain will then go back to what it was beforehand and try and restore the weight. So sometimes people will elect to use them temporarily if their plan was never a weight loss journey, but they need to do so for an operation like a prostate cancer surgery or a knee surgery. They can use them in the short term, supervised with their doctor. But if they want to keep the weight off, it's something that they need to consider as a lifelong intervention.
And I suppose everyone's going to want to know, like, safety with people with cancer and things like that. They're safe to use in that.
Yes. Yeah. The thing that we have to be careful of is if they're having some chemotherapy. So different cancers require different treatments. And if people are having chemotherapy, we need to be very careful about how quickly they lose weight because it affects their chemotherapy dose. So we would talk to their oncologist in that situation and make sure that the weight loss is controlled according to what the oncologist wants as well. But when we're preparing for surgery in the absence of chemotherapy, they're absolutely fine to use. And I will just mention that obesity itself actually drives 13 different types of cancer. So obesity is a catalyst for prostate cancer, for pancreatic cancer, for bowel cancer, breast cancer, thyroid cancer, multiple cancers in the body. And so weight reduction can help you to reduce your risk of developing cancers. You did mention that very interesting study in the beginning about whether or not these GLP-1s will form a treatment for prostate cancer or cancer recurrence, of which I'm really excited to see what those studies do show. And as you said, there's no hard evidence at the moment, but it's definitely a watch this space.
Yeah, because there was a fascinating study as well that was looking at it was a database study out of somewhere Scandinavian, Finland, Norway, or somewhere, and it was quite fascinating. One of the studies where it was men who had used GLP-1 medications had a significantly lower 10-year risk of metastasis and all-cause mortality compared to those using insulin or metformin.
Mm.
And like the 10-year metastasis risk was 73% lower compared to those using insulin alone. So, which is quite fascinating.
Yeah.
Which is an observational study, of course. But it'd be interesting to see where things go from there, and what other, like every month or so you'll see online that there's GLP-1s have been linked with doing something else funky in the body in a positive
Yes.
way,
Yes.
which is interesting.
And you
Yeah,
do wonder, is it related to the molecule or is it related to the weight loss that we're seeing these benefits? And
yeah,
we won't know until the studies are performed. I suppose linking back to your question, I didn't really answer with regards to safety of these medications. They are very safe. We've been using them for 20 years in our most high risk cohort, which is the type 2 diabetics. There's, of course, considerations that you need to take at an individual level. So it's very important that people discuss with their doctor whether they are a suitable candidate for GLP-1 medications. But in general, there's very few contraindications, which means very few people that can't have.
And what about access in Australia? So is this there's obviously going to be online things that pop up all the time, which probably not advisable. But in terms of patients, not in our local area that can come in and see you guys, but more rural areas and things like that. Like, how are GPs kind of? I mean, obviously it's going to be individual, but across the board, how are GPs finding prescribing these medications and things like that?
It's the hot topic of the decade for GPs, so it's being rammed down their throats. And like I said, if the GP is not seeking out the information, then the patients are demanding it of them. And so most GPs will absolutely know how to prescribe. In terms of supply, we have abundant supply of both weekly weight loss injections in Australia. We do also have a daily injection. I wouldn't recommend that one because it's not very much weight loss and it's horrible side effects. It's pretty much been superseded by the weekly injections. Challenges that gentlemen might face if they're living rurally or regionally is actually just getting the drug into town, but the pharmacists can order it in. So they may need to just wait a few days for the next delivery, but in terms of the warehouses, they're full, and both of the brands of weekly weight loss injections are in great supply, and they're both excellent. So you could pick one or the other and you'll have no problem.
Then everyone will always want to know about funding. I understand it kind of there's Medicare, well, PBS kind of for diabetes from memory. And then if it's a private script or they're not eligible for funding, what's a kind of rough guideline in terms of the prescription per month?
It's so with type 2 diabetes, you still need to jump through a few hoops to actually meet the Medicare or the PBS criteria, I should say. But your GP will be able to help you figure that out as the patient. If you're using it for weight management, there is no weight loss medication currently under the PBS for weight management. So unfortunately, it does fall down to the patient to privately fund it. However, if you have private health insurance, it's important to collect your receipts from the pharmacy because often your private health fund will give you a little bit of money back depending on your level of cover that you have, if there's any pharmacy cover. Depends on what script you get from your GP. Now, we're not allowed to mention drug names because of TGA guidelines, but the cost of medication will range anywhere from $130 a month up to about $400 a month. I typically find my patients don't need more than the starting doses of these medications. There is one of the medications that will go up all the way up to $695 per month. We have 1,700 patients in our clinic. There's 3 patients on that dose in our clinic. Most patients are on the first 2 doses of that particular drug, and of the other one, they're only on the starting 3 doses, which works out to be about 130 to 260 a month.
Yeah, right. There you go. And then Jono and Paige, this one for both of you, but like when patients are not necessarily your patients, Jono, but other patients from up and down the East Coast, and you start mentioning weight loss and they've been asked to lose weight by the urologists. You sometimes get the I'd rather not cheat. I don't want to do it that way. I want to do it the proper way, kind of thing. How do you broach these conversations, or do you just tell them to go see Paige and she'll sort it out?
Yeah, it's a great question, and I think often the patients that we see are a little older. They're between well, I'm not going to say older is 40, usually between 50 and 70 plus years old, and when you have a chat to them, they've usually had a long battle with weight gain and loss throughout their lives, and probably at a point where it's pretty tough to alter their BMI at that particular stage of life, I think. And so not only that, but then you're giving them a diagnosis of prostate cancer, which is a horrible thing to start with. And then you're saying, right now, I want you to lose all this weight as well. And so I generally say, look, it's a big team effort, and that's what treating prostate cancer is all about. It's having a great team involved, as you both know. But part of that team is a life-changing pathway of altering your dietary habits and trying to make people feel better throughout the whole process, not burden them with having to go away and think, okay, well, actually, I've also got to now lose 7 to 10 kilos or whatever it is before having a procedure done, which puts a lot of extra additional pressure on. And so, yeah, it's still not easy to do that with the whole team involved. There's still a lot of barriers there, but having Paige and the team there makes a huge difference. And those patients that head along and say hi are generally the ones that have lost all the weight that come and see us and typically are feeling a lot better. We also involve the family, as I'm sure Paige and the team do as well. But on top of that, the GPs are also involved too. It's something that the GPs may not have a lot of time to manage as well, especially I see patients from all over Queensland. But you mentioned the rural setting before. Some of these GPs have got hundreds of patients they're seeing a week, and so maybe not as much time as they'd like to sit down and discuss those life-changing habits that can form, and also provide the support as well for those particular habits too. So that's where the team comes massively into play in that setting and diagnosis. So yeah, it is easy to say, yeah, come head along and say hi to Paige, and you'll probably drop it very, very quickly. But there's a great process in place there, and it's well structured, and we know that it works, and we know that those patients not only lose the weight, but they end up keeping that weight off, which is the super important part, and probably the thing that extends their life expectancy out the most, to be fair with you. It's really super important.
I think what we know is that obesity is a chronic disease. It's not a failure of a person's willpower or their ability to actually lose weight. People who live in larger bodies have tried to lose weight throughout their lifetime, and the way that the brain is designed is to restore our weight. When we were cave girls and boys, if we lost weight, we would die. And if we died, we were not continuing the species. So our biology is framed to avoid weight loss at all costs. And when we live in 2026 in the environment in which we live, this environment is called an obesogenic environment. We have abundance of highly processed food and calories at our fingertips, and we're very sedentary compared to when we were cave girls and boys. But our biology remains the same. And so to say to somebody, go and lose weight, it's far easier said than done, which is why when we talk with our patients, we run through the biology. We go through their medical history and we talk to them about whether these medications are suitable for them. It's definitely not cheating, neither is bariatric surgery. Some people do require assistance with weight management. We can typically see up to 5% weight loss can be achieved and maintained with diet and lifestyle interventions alone. But anything beyond that, and people will generally require support. So anything between about 5% and 20% can be achieved with medications. And there is a medication that's coming in the pipeline that's showing 28.5% weight loss that will be available in the next few years. But currently, bariatric surgery remains our strongest weight loss intervention with a weight loss of around 30 to 34%. And Jono will know for some patients, if we've got the time and we absolutely have to do this, we sometimes do bariatric surgery to then be able to do cancer surgeries like prostate cancer surgery or bowel cancer surgery in patients who have significant obesity and require that to actually be operable. So no, medications are not the easy way out, and it's certainly not a cheat. And for some people, maybe seeing the dietitian is the only thing that they do need. And so particularly for rural and remote patients, if their GP is struggling for time, then sometimes just seeing the dietitian, and we've got quite a few via telehealth, can provide that support for them, or the GP can do the prescription and then the dietitian can lead them through the rest of the treatment. The local GP is an absolutely important team member, and if they can't do it though, then they can refer to services like ours, of which there's quite a few around Australia that can just wrap you up, help you with that weight loss in preparation for surgery, and either hand you back to the GP or look after you lifelong.
And in terms of the other team, like, so you've got the dietitians on board. Most of the men I've seen that have, they're doing a combination of medications and some kind of dietary modification as well.
Yes.
Most of them will see the dietitian as well.
Yes.
And what role do they play in terms of helping with this?
I think they're the most important player in the weight loss space because they help you to lose weight safely. We don't want patients going into theatre malnourished. You will have worse outcomes from your anaesthetic. But not only that, Dr. Chambers is about to remove a piece of your anatomy and then join two pieces back together. And we need that to heal. And when you're having an operation, your body goes into a state called catabolism. It starts to consume protein to try and heal that area. And if you're going into the procedure and you're already malnourished, the body's going to struggle to heal that surgical site. And so we'll see increased risks of wound breakdown. We'll see increased risks of anastomosis, which is that joint in the urethra breaking down. We can see a lot of other problems with electrolyte issues, cardiac issues immediately post-op. So the nutritionist or dietitian plays an essential role in supporting a patient's nutrition while they also at the same time losing weight, because remember, we need to put you in a calorie deficit, but we need to make sure that your protein and your nutrients are in good stead for you to go and have that operation. And they help you with your bowel as well before surgery, because we're about to make you pretty constipated as well. And so having that dietitian on your team can help you to get your bowel nice and healthy beforehand, but also manage that constipation that you might experience post-operatively as well.
Yes, there is nothing anyone else fears than being constipated for catheter in.
Yes.
No,
Not an
awful.
enjoyable experience.
Yeah.
Any kind of recommended kind of multivitamins or other supplements that sometimes these men need to help during this journey?
Not in particular, because sometimes those funky pills and preparations and things can actually cause issues with bleeding, surgical bleeding. So we prefer you to not be taking funny multivitamins. Jono, correct me if I'm wrong.
That's perfect.
But really, protein is the focus. So we want you to be well nourished from a protein perspective. Not all proteins are created equal. So your collagen-based proteins are different to your whey-based proteins. There's animal proteins from that beautiful steak that you have on a Friday night. And then there's plant-based proteins as well. And different people have different protein requirements per day. But protein is the key, and fiber as well, because as we mentioned with the bowel motions, we want nice, healthy bowel movements, and fiber is an important nutrient to consider. So as a blanket rule, no, you don't need to be taking multivitamins, but we do a full set of nutritional blood tests in our workup for our patients. And so if we find any deficiencies, we will deliberately supplement for that particular deficiency.
The other question that people will often ask is, so if they can't afford to do GLP-1 medications, then often the next question will be, what's the best diet for weight loss? Is there, like, obviously reducing calories and we want to keep protein, but is there anything other specific diets they should look at, like Mediterranean will get a run, different things, low carb, high protein kind of thing?
They'll have to be in a calorie deficit to lose weight. And any diet I would always recommend doing under the care of a dietitian, because they just get it right. We We didn't even learn anything in medical school about diet and nutrition. I don't know, did we? So it's a big learning curve for us as well as clinicians to understand. So dietitians know their stuff. When we have a very short time period to surgery. So if we have 4 to 6 weeks, we will put a patient on something called a very low calorie diet or a very low energy diet, VLED. And this is a scientifically constructed meal replacement program, basically. And it requires shakes, soups, or bars that have been formulated as a complete meal replacement. And you can lose significant amount of visceral fat, which is that fat we want to lose before surgery, very quickly, but it needs to be under the care of a doctor or a dietitian who knows how to prescribe these things. And so if a gentleman only has a few weeks, the VLED diet would be the best thing to do. But I would encourage him not to self-direct that because some people have to be very careful, particularly if they have kidney disease. There's some electrolyte considerations there with those products. And otherwise, a Mediterranean diet or low carb diet or intermittent fasting program, whatever suits him. If it's resulting in healthy weight loss, then go for it.
Yeah. And John, you probably get this one a bit from patients possibly, but they'll often ask, caveman and carnivore and zero sugar diets get a fair run on the old YouTube at times in terms of ways to both, you'll see videos that are both just preparing for surgery, but also as a way to eliminate the cancer in inverted commas. Any evidence that's been of late that shows any of this is actually going to work, or is it just not quite going to make the mark?
Yeah, that's a good question. I mean, I think everyone is really in the situation that they are looking for that sort of magic cure sometimes. And unfortunately, right, it doesn't, there's nothing there that's a magic bullet. In terms of diet, with the diagnosis of prostate cancer, the biggest things that we see that are going to affect the patient pathway really is reducing the visceral fat. So however we can do that, reducing the inflammatory state, improving your insulin resistance, and then that also will impact on things like the need for use of androgen deprivation therapy and how that plays into our prostate cancer treatment as well, because that can also impact that pathway. And so, yeah, there's no specific type of diet that we recommend as a urologist that's going to be protective from a cancer control perspective. It's mainly just optimizing the body physiologically so that it's more capable of fighting a cancer and getting through treatment. Certainly, there are things that have some benefit, lycopenes in tomatoes and things like that. Perhaps have some improved, perhaps increase the or are beneficial for the protection against prostate cancer earlier on in life and things. But there's not a lot of evidence once you've got a diagnosis that there's any particular pathway that's going to be improving your risk there of progression or even treatment as such on its own.
Yeah. So, yeah, I probably should have split it up a little bit because, yeah, definitely your Gleason 7, 8, 9s, it's not, diet alone is not going to reverse anything. There's, like we talked about earlier, if someone's on active surveillance, then definitely improving the inflammatory environment through visceral fat reduction and exercise and resistance training. We do see that people potentially can stay on active surveillance for longer. And they're also definitely in a way better shape if and when they do need treatment, depending on age and a whole range of other factors.
Yeah, you're right. Well, I mean, Paige mentioned before that obesity is a significant risk factor for a number of different cancers, prostate being one of them, and kidney cancer. So yeah, it certainly is. Whatever you can do to get that risk factor reduced will help improve your chance there.
And then I was just going to ask another question because we just mentioned it before, but ADT, so hormone deprivation therapy, which drops testosterone and basically halts cancer growth, but also has a whole range of other kind of side effects. How do you go around how's the juggle with deciding whether I kind of need to put this person on ADT, but I also need them to lose weight before surgery? How do you find the balancing act in those kind of cases?
Yeah, that's a great question. Usually, and hopefully, we're not utilising ADT with surgery too much, but with some prostate cancer treatments, we definitely do. So it's used as an adjuvant treatment in radiation therapy, for example. The two really complement each other, I think, in terms of, they both will theoretically work more effectively used in conjunction, in terms of increasing insulin resistance, uh, and promoting a more rapid metabolism, promoting reduction in your intra-abdominal visceral fat is going to help in terms of your outcomes in general. And so if you can reduce that, then you're going to counteract those androgen deprivation therapy effects as well of potentially the other pathway there too. So they do work kind of hand in hand there, really. And so I feel as though they'd be very beneficial to use together.
Yeah. And I think that's where, like, if there's a potential that post-surgery someone, the margin may not be as clear as hoped or something like that. Like, that's where doing weight loss with a team like yours, Paige, to maximize the muscle mass and not losing the muscle mass while on a weight loss journey is the key, because the potential for ADT or radiation down the track will make that significantly worse, which can then lead to frailty and a whole range of other osteoporosis and other kind of issues as people get older.
Absolutely. And that's an incredibly important point, I think, Tom. And that's the media, we're starting to talk about that. Patients are talking about it, health professionals are talking about this sarcopenic risk. And for the listeners at home, sarcopenia is a disease state where you have very little muscle mass, and it leads to things like frailty, falls, broken bones, early admission into nursing homes, or premature death. And any form of weight loss will result in some what we call lean tissue loss. So not only will a person lose fat mass, but they'll lose what we call lean tissue, which incorporates organ weight, water weight, and skeletal muscle. Now, what we do here is we have a body composition machine. So we actually measure how much fat mass and how much skeletal muscle mass a person is losing. What we see in clinical trial, and it actually differs a little bit between the two medications, so I wish I could delve into it in more detail, but we see typically with GLP-1 somewhere between 25 and 40% of the weight loss is from lean tissue loss. So that's not just skeletal muscle. So we would expect around 15 to maybe 20% of it skeletal muscle, which is something you will see with any weight loss intervention, even with diet and lifestyle change. But as you know, Tom, is we want that muscle to not only be present and remain there, but we want it to be functional. And so we know that it's okay to lose a bit, but we want it to be a powerful, strong muscle. And so monitoring muscle function during weight loss with, say, a sit-to-stand test or a grip strength test, see how strong a patient is, that can give us some really good indication as to how their health and longevity is going to be. And resistance training, so lifting weights and lifting heavy weights within your own limitations and safety, and progressively making those weights more challenging as you go, helps you to protect your skeletal muscle mass, but also function. And dietary protein is the other key as well. So your exercise physiologists, your physiotherapists and dietitians are really your best friends when you're on a weight management journey and a health journey.
We love resistance training. It's the best.
Yes. No one else likes it. You like dishing it out. We don't like
it can be
doing
a challenging conversation, but it's definitely once you just write over 2 pages of benefits, people start to go, all right, shut up, Tom. Well, I'll just do it. So
it is so therapeutic in so many different ways that we prescribe it for everyone, every single patient.
Yeah. All right, we'll move on to a final little takeaway. So, Jono, in terms of getting someone ready for surgery, any final little top tips or things that you'd like everyone to kind of know along their journey?
Yeah, I mean, I think probably the big key and takeaway is that that the prostate cancer journey is a journey, and surgery is a journey, and it's quite a team-based pathway. It doesn't just involve your GP and your surgeon. It does involve quite a big team, and that's for a reason. But we have a huge amount of resource that goes into education and optimization before, during, and after surgery, and then long-term ongoing. And so I think the big keys there, from my perspective, are your support. And so from a surgical perspective, that's we have a lot of people involved. As you know, Tom, very important for prehab pelvic physiotherapy. Is a super important role there for a range of different, not only your continence and functional outcomes, but your actual recovery outcomes as well. Paige and the team at MedSurg Weight Loss, we have prostate cancer oncopsychologists that we are involved with the process, prostate cancer nurses all throughout the state. Our practice, the GPs are very important there too. And then the wider general nursing and oncology teams involved. So information is super important. Sometimes you get a bit too much information down this pathway of prostate cancer, but being able to access the team and the right people is a really important step in that journey. And I think having access to the information, having access to the right people, all comes down to much better outcomes. And that's what we all want at the end of the day, is prostate cancer to be treated as effectively as it possibly can, with an outcome that is excellent for the patient and their family moving forward too.
Yeah, absolutely. I think one of my favorite cohort to look after is men. Men don't seek out help with their health, and often it will come to a crisis point before we as doctors finally get our claws into you. And so I would just encourage men to um, allow themselves to just be looked after by this team, because it's very daunting. You're facing a cancer diagnosis, which is terrifying. You're facing losing your erectile function. You're facing losing your continence. This is a scary as hell moment for gentlemen. And we have a really great team, all of us, from the pelvic floor physios, Tom, to the surgeons, to like Jono mentioned, all of those team members allow us to wrap you up and look after you and take care of you and take off some of that stress and burden. We will help you through this, and you can often thrive afterwards. You will be okay. We'll get you through safely. And I would just encourage gentlemen to really lean into those supports that they have, because you do have an opportunity to then get through it, but also to thrive and become a new healthy man. And you don't want to survive your prostate cancer and then die of your heart attack, which, cardiovascular disease we didn't touch on today, but it's still the number one cause of death for men in this country. And weight reduction can help you in that regard as well. So this is a scary thing that you're facing, but it's something that you can overcome, you can get through, and that you can achieve significant health gains beyond.
Yeah. I sometimes cheekily say to patients when they say, why are you guys obsessed with me walking so quickly after surgery? And sometimes I'll cheekily say something like, well, now Jono's removed your prostate, you're now much more statistically likely to die from a heart attack than the prostate cancer.
Exactly. Let's get
You do need to keep moving, kind of thing.
Yes.
So that's great. And I think, there's nothing better than when a patient comes in a couple of weeks after the catheter comes out, and, they just kind of report everything that everyone in the team told me, it just went exactly as you said. And everything was exactly like I'd been told, even though I might not have taken it at the time. But when it happened, I'd been told about it, and it all just went. There was no kind of shocks or surprises anymore, which is where the team kind of really comes involved, which is great. So I think that's about all my questions for tonight. So I do want to thank you both for joining us. I'll put some links to where they can find you at Brisbane Urology Clinic and MedSurg clinics as well. And so thanks, Jono and Paige, for this. It'd be a really handy resource for patients going forward. And who knows, in a couple of years' time, we might be back talking about all kinds of other things that they've found out about GLP-1s and prostate cancer. So,
no doubt. Thank
yeah.
you, Tom. Thanks for having us.
Thanks.
Yeah, thanks so much.